Welcome to the Weekly Neurology Deep Dive, produced by Amer Gavanini. Our mission is to extract the most critical clinical knowledge from recent papers and translate it directly into insights you can use in your daily practice. Today, we're tackling a topic that causes a lot of anxiety for both patients and clinicians: the long-term outlook for seizures linked to cerebral cavernous malformations, or CCMs. We're diving into the paper Seizures and Epilepsy in Patients with Untreated Cerebral Cavernous Malformations by Sandman and colleagues. This is a paper that I think finally gives us some solid long-term answers about conservative management. Now, before we get into the data, a quick reminder. This deep dive is for education purpose only. It has no commercial goal, and it's a summary. We really recommend you consult the full paper for the complete data. The core challenge this study addresses is that clinical decision point. A patient has a CCM, maybe they've had a seizure. Do we watch and wait, or do we intervene? We've been missing consistent long-term evidence on medical management alone. But this paper, it delivers that evidence from a prospective population-based cohort in Scotland.
With a median follow-up of 15 years. This is the kind of data that can actually change counseling.
It absolutely is. And for anyone walking into clinic right now, if you need the immediate summary, here are the 3 major takeaways that will guide your next decision. First, the long-term risk of a first-ever seizure in an asymptomatic patient, the one you found on an incidental MRI, is low. The 10-year risk is only about 6%. This is your justification for telling patients that prophylactic anti-seizure medicine is not indicated. You can counsel against it with confidence.
So, no need to start medicine on an incidental finding? What's the second point?
The second point is, the moment a patient does present with a first unprovoked seizure from a CCM, you should treat immediately. The risk of that seizure recurring within 10 years is high, about 80%. This clearly justifies a diagnosis of CCM-related epilepsy after just that one single unprovoked seizure.
And the third point, which sounds like the most reassuring part of this.
It is. Long-term seizure control is very achievable with medical management alone. About 82% of patients achieve 2-year seizure freedom within 10 years. And very often this is done with just monotherapy. It confirms surgery is for cases that truly fail medical treatment, not as a first-line measure.
Okay, let's unpack this. Those conclusions are incredibly clear, but their power really comes from the study's methodology. This wasn't a retrospective study from a specialty center. It was, as you said, a prospective, population-based inception cohort from Scotland.
And that inception cohort design is what's so important. It minimizes selection bias. They captured adults, anyone aged 16 or older, who were newly diagnosed with a CCM. So they got patients right at their baseline before major treatment decisions were made.
Can you tell us about the scale? How many patients were followed for that long?
The cohort included 300 patients with a median age of 44. About 53% were female. And crucially, the median follow-up was 15 years.
15 years.
That's enough time to track a patient and really establish long-term risk. That duration is what makes this data so powerful.
And what about the CCMs themselves, anatomically?
About 72% were supratentorial, and about 18% were in a location we all worry about, superficial, involving the temporal cortex.
The ones we've historically thought were the most epileptogenic.
Exactly. And in terms of how they presented, it was interesting. About 44% were incidental findings, maybe found during a headache workup. Only about 33% of the cohort initially presented with epileptic seizures.
So we have this diverse representative group. Over that 15-year period, what was the overall seizure burden?
Over the long-term follow-up, about 33% of all patients experienced an epileptic seizure at some point after their diagnosis. The paper then used multivariable analysis to figure out what made those patients different.
And 2 risk factors really stood out for experiencing any seizure. The first one is age.
That's correct. Younger age was significantly associated with a higher risk. The adjusted hazard ratio was 0.82 per 10-year increase in age. What that translates to clinically is that this is more of a young person's problem. A patient diagnosed at 20 has a much higher long-term seizure risk than one diagnosed at 60.
And the second factor, the mode of presentation, was just overwhelmingly significant.
Absolutely. Patients who first presented with a seizure had an adjusted hazard ratio of 12.94.
So almost a 13-fold increase in risk compared to an incidental presentation.
It's a huge signal. It tells us that if the CCM has already proven itself to be epileptogenic, that pattern is almost certainly going to continue.
What's surprising, though, and I think this goes against a lot of traditional thinking, is what didn't show up as a significant risk factor. We always worry about the largest CCM diameter, or if there are multiple CCMs, or especially that temporal cortical location.
I agree that finding is a major shift. In the final multivariable model, none of those anatomical features, not location, not size, not multiplicity, were significantly associated with the occurrence of any seizure.
Why do you think that is?
Hmm.
We spend so much clinical time focused on whether a lesion touches the temporal cortex.
It's a profound question. Perhaps over a 15-year period, the sheer fact of having seized once is just a far more dominant prognostic factor than the anatomy itself. For long-term risk, it seems the initial clinical presentation trumps all those anatomical features we've worried about. That should change our initial counseling.
That's a powerful point. Let's pivot to that asymptomatic group, because this is where we really get to the question of prophylaxis.
Yeah.
We're talking about the 189 patients who never had a seizure before or at their initial presentation,
And for them, the critical data point is the rate of a first-ever seizure within 10 years.
which was incredibly low, only about 6%. And all of those first seizures happened in patients with supratentorial CCMs.
This is probably the most actionable piece of counseling data in the paper. With a conversion rate of only about 6% over a decade, the clinical mandate is clear. Prophylactic anti-seizure medicine is just not indicated for asymptomatic patients. The risk of side effects from a long-term medication clearly outweighs the minimal benefit.
And that finding also applies to the group that presents with a hemorrhage but doesn't have a seizure.
Exactly. It aligns with the general findings for hemorrhagic stroke, providing more reassurance that we're not missing an opportunity by waiting. We're waiting for a low probability event.
So we've established the risk of a first seizure is low. But what happens when that first seizure occurs? That's an immediate life disruption for the patient. Do we start medicine right away, or do we wait for a second event, which is standard for many other epilepsies?
The paper addresses that head-on. They analyzed the 64 patients who had a first unprovoked seizure during the study. The findings here are, well, they're non-negotiable.
The recurrence rate was shocking. About 77% of these patients had another seizure, and the cumulative risk within 10 years was about 80%.
That 80% risk gives us immediate clinical justification. The International League Against Epilepsy, the ILE, says you can diagnose epilepsy if the recurrence risk after a first unprovoked seizure is over 60% within 10 years.
And at 80%, we are well over that threshold.
Well over, so we don't need to wait. The diagnosis of CCM-related epilepsy is justified after that very first unprovoked seizure, and we should be treating immediately.
That brings a lot of clarity. You're not waiting for a second event. The underlying lesion provides that justification from the start.
And the risk is front-loaded. The highest chance of recurrence was in the first year after that initial seizure, a rate of about 64%. That really confirms the urgency.
Did the study show that starting anti-seizure medicine actually helped?
It did. The observational data strongly supports it. Starting anti-seizure medicine after the first seizure was significantly associated with a lower recurrence risk. The adjusted hazard ratio was 0.36. This supports the guideline to prescribe after that first seizure. The treatment works.
Let's turn to the long-term prognosis for patients who are diagnosed with CCM-related epilepsy and managed medically. This is so important for patient counseling. How successful are we really?
The analysis looked at 110 patients with definite or probable CCM-related epilepsy, and they focused on 2-year and 5-year seizure freedom, which are really the most meaningful clinical metrics.
And the success rates are extremely positive. This should be very reassuring for our patients.
They are. 2-year seizure freedom was achieved by about 68% of patients, but the 10-year cumulative rate reached about 82%. For 5-year seizure freedom, it was about 55%, with a 10-year cumulative rate of about 62%.
Achieving 2-year seizure freedom in over 80% of patients over a decade is a fantastic outcome. It suggests this is a medically responsive epilepsy syndrome.
It's remarkably responsive. And here's maybe the most impressive detail, the role of monotherapy. The majority of patients who achieved 2-year seizure freedom, about 59% of them, were on a single anti-seizure medicine. For 5-year freedom, that number was even higher, at about 67%.
So we are not just achieving control with polytherapy and side effects. We are achieving sustained, long-term control, often with just one agent. This shows that medical management is sufficient for the majority of these patients without needing to take on surgical risks.
That's right. And the study also reinforced that you can't predict who will respond based on their anatomy. Covariates like age, sex, and location were not significantly associated with achieving seizure freedom. The clinical response is the true marker.
And for that remaining group, the ones who do develop medically intractable seizures, surgery is still the next step.
Absolutely. The paper suggests that needing multiple medications is a good sign that medical management might be failing and an intervention should be considered. The data really solidifies the role of surgery for refractory cases, but firmly establishes conservative medical management as the appropriate first-line, long-term approach for most.
Let's summarize those 3 core clinical points one last time, just to make sure the take-home message is crystal clear. Number 1, for your asymptomatic patients, the 10-year risk of a first seizure is low, about 6%. No prophylactic anti-seizure medicine is needed.
Correct.
Number 2, the recurrence risk after a first unprovoked seizure is very high, about 80% within 10 years. You can use this to justify an immediate epilepsy diagnosis and start treatment right away.
That's the key implication.
And number 3, long-term seizure freedom is highly achievable with medical management. About 82% get to 2-year freedom within 10 years, frequently on just monotherapy.
These long-term findings are incredibly valuable for counseling and for initial treatment, and they really reduce the uncertainty we've all felt. But, and this is important, despite these very strong observational results, the authors do emphasize one critical next step.
And with that?
We still need a randomized controlled trial. That's the only way to settle the remaining uncertainties about the optimal timing and approach for intervention versus continued medical management for that small subset of patients who become truly medically intractable. That is the next hurdle to definitively guide our approach for those refractory cases.
Fascinating data, really confirming the success of a conservative approach for most of our patients. Thank you for joining us for this deep dive.
Yeah.
And we encourage you to consult the full paper by Sandman and colleagues for the complete data and analysis.